and welcome to our Department of Medicine's Grand Rounds. On behalf of the Division of Geriatrics and the HRSA, the Brooklyn Initiative to Develop Geriatric Education, it is my honor to introduce our speaker for today. Our speaker for today is Dr. Dharmarajan. Dr. Dharmarajan is the Vice Chairman of the Department of Medicine, the Clinical Director of the Division of Geriatrics, and the Geriatric Medicine Fellowship Program Director at Montefiore. He is also a Professor of Medicine at Albert Einstein College of Medicine, Brooklyn, New York, and he's an adjunct professor of medicine at New York Medical College. Dr. Dharmarajan is a former professor of medicine and associate dean at New York College of Medicine, Valhalla campus, and he's the chair of the Department of Medicine at Our Lady of Mercy Medical Center until his recent transition to Monty. Dr. Dharmarajan is certified by the American Boards of Internal Medicine. He's also certified in nephrology and geriatric medicine. And he's also a fellow of the American Geriatric Society. He has masters of the American College of Physicians and fellow of Royal College of Physicians. Dr. Dharmarajan was instrumental in developing a very reputable inpatient geriatric program at Our Lady of Mercy Medical Center in the Bronx, currently Montefiore Medical Center, with clinical, academic, and research components, including a fully accredited fellowship program, which has 10 geriatric fellows. Dr. Dharmarajan has also co-edited textbooks, the textbook of clinical geriatrics and the textbook of geriatric gastroenterology. In addition, Dr. D has authored and edited approximately 200 publications in peer-reviewed journals and textbooks. He has over 500 scientific abstracts and presentations locally, nationally, and internationally. He has been a principal investigator for several research projects, including a national multi-center study for the AMDA Foundation. He has won the Howard Gutterman Award for Best Research Project in the National Annual AMDA meetings. And more recently at Monty, he received the first prize for Best Clinical Science Paper. He received a Lifetime Achievement Award at New York City in April of 2019. And in the same year, he received recognition for leadership and community services from Monty. Dr. D. Dharmarajan is instrumental in teaching and mentoring young physicians. Some of his many recognitions in medicine include Teacher of the Year, peer-to-peer recognition by the Bronx County Society, dedication as teacher and mentor to young physicians in the Bronx, and unparalleled leadership in medical community for medicine and research. In 2003, he was featured on the cover of Aging Well magazine, and he was featured as one of the 5 noteworthy geriatricians. So in terms of his accomplishments and in terms of his awards and honors and recognitions, I can probably easily spend the next hour talking about Dr. Dharmarajan. So without any further delay, it is truly my esteemed honor to welcome Dr. Dharmarajan to today's Grand Rounds, and we're looking forward to his presentation.
Thank you very much, Dr. Prosper. And I thank also Dr. Reinhardt and Donovan and the 2 chief residents, all for working with me and putting up with my requests and the difficult things that I have asked in order to prepare for this presentation. When I was asked to speak on this book, the title is Geriatric Gastroenterology, which is going to come out within days, within the very early part of next month, about 2,400 pages and 3 volumes. I did not know where to begin and where to end. So I have called it a selection of pearls, and I'm going to try to see what I can do in terms of the time that we have at our disposal. I'm sorry for the little confusion at the beginning of the talk, but let's hope the rest will go smoothly. So no conflicts. I will not repeat the objectives which have already been stated in my paperwork earlier, but my plan is to give you a brief introduction to aging, and then we will go on to more selectively problems relating to the gastrointestinal tract or system in relation to older people. So number one, we need to know that it's not that the GI tract, but all of our body declines in its function as we go from the 20s or 30s when we peak, and I'm sorry to tell you that, towards older age. So essentially a shrinking of what we call as function or reserves, We are fine at rest, but when we are faced with difficulties, such as the stress of illness, we find it hard to cope. We also therefore become vulnerable to disease. This shrinkage is termed by some as homeostenosis. When one dies, eventually, it's wrong to say he died of old age. Most of the times, there is a cause of death. If you're perfectly healthy, you can live on to become a centenarian, and the centenarians are actually on the increase in this country as well as worldwide. And the super centenarians is the hardest number to attain. From 100 to 110, it's very difficult. And the super centenarians are not just going up in number, but they are far fewer. If you look at the nature of the illnesses that cause death, the most important is heart disease. But the more striking fact, and this is from our CDC data, is the dramatic decline in heart disease over the last 20 to 30 years. This is amazing. And this is due to all the preventive measures we are taking. So the hospitals prepared for a lot of beds for an increasing number of heart disease as the cause of illness and hospitalizations, but look at what has happened. We have not done as well as heart disease in terms of cancer. There's a little decline, but as you get older, cancer is bound to occur from changes in your cells. The decline in heart disease is matched for stroke. So the two vascular events decline. So what is it that we finally die from? A lot from influenza and pneumonia, both preventable, yet many die for failure to do the basic steps like taking the vaccine. We die of something else known as Alzheimer's disease. It's about number 6. As you live longer and longer and longer, there's a higher and higher likelihood that you can get Alzheimer's disease. We have yet to find a good preventive method for Alzheimer's disease, nor a cure. When you go further down, what is not visible here is accidents, driving accidents, or accidents from falls. The American Geriatric Society has stated 5 M's as to what matter to the patient and what we should keep in mind. And in your evaluation, you recognize the patient's mind and emotions, the ability to move, because failure to do that impedes everything that this patient wants to do, the medications which are entirely in your hand, the importance of recognizing a multi-complex disorder invariably in most, and finally asking a patient a simple question: what is it that matters to you? I'm going to do all this, but what matters to you? And that's really what you need to address. It doesn't matter what you attempt to do, but it should matter to the patient. There's going to be a huge, I would say in relative terms in this talk, importance given to medications in terms of how much polypharmacy is rampant in terms of our day-to-day practice, and what is now known as de-prescribing to address polypharmacy. When you communicate with the patient, make it simple. Have a bright room so that the patient can see you. Remember, most patients have a problem with hearing, and many have a problem with vision. You don't want glare on the patient's face, but you want a bright enough room they can see you. Speak loudly and clearly. Having a mask these days is actually a hindrance because they can't read your lips. You need to keep that in mind. The patient may not hear you at all. And if you repeat a sentence, use different words, not the same sentence over and over again. And if that fails, you may have to consider writing. We all think older patients complain a lot, and that's really not true. In relative terms of how ill they are and how many disorders they suffer from, if a brand new patient comes to me, at the end of the visit, I would be able to easily say that if the patient is 70 or 80, they have at least 5 to 6 problems at a minimum, and maybe more. They are not aware of their illness. They are sometimes in denial. They think everything is due to old age, which is not true. As I said, it's more due to a medical or surgical or other forms of illness, a psychiatric illness. It's illness rather than age. There's a high likelihood of cognitive disorders and depression. They're afraid to come to you because of cost, and they believe that nothing can be done or they will end up in the hospital. So one of the first things you should do, irrespective of what specialty you practice, it doesn't matter whether you're a surgeon or a physician or a cardiologist, doesn't matter. you need to understand these two terms, capacity and cognition, and they are not the same. Capacity refers to medical decision-making capacity. So what is capacity? Can the patient understand you? Can the patient express a choice as to what this patient wants, appreciate what is being done, and reason as to what would happen if the choice was different? Hello, giving a grand rounds. Appreciate and reason. By reason, I mean, what would happen if this patient was not going to accept your choice, or is there an alternate? Is there a surgical approach, a medical approach, or doing nothing? Can this patient be consistent? And this term is different from the word competence, which we should hardly ever use, which is a legal term. But when you say capacity, you also need to figure cognition. And while I'm not going to speak to you on dementia, cognition means the process where you have existing knowledge and you use it, or you have the ability to acquire new knowledge. So it's existing and new knowledge, and using a bunch of processes, which are many. Memory, we all think it's memory. Memory is only one aspect. Can you recall? Can you recall what was being said in this lecture tomorrow? Can you add knowledge? Can you rationalize? Can you reason? Can you solve problems? Like we had a problem this morning with the Zoom. Can you solve it? All this is cognition. So capacity, a patient with mild dementia or impaired cognition can have capacity. We should not equate the two. Why should we screen for cognition? Because it's not recognized. Sadly, it's not recognized. I see that in the hospital many times in the interdisciplinary rounds, the staff is too quick to blame a patient. And I would often end up asking the question to the primary team, by the way, did you check the patient's cognition? And next day they would say, the cognition is grossly impaired. So I would say, now go to plan B, and that is to ensure that you deal with someone else or a caregiver to handle this patient's insulin dosing, because they were stating that this patient was not adhering to treatment. So that is a consequence. A consequence of cognitive impairment is non-adherence, and the result of taking medications without a proper basis, adverse events, the proneness to a confused state or delirium, and the burden to everyone, to the caregiver and to the society. A cognitively impaired patient could drive and get into a car accident, and that's a burden to society. So all this happens, and you need to recognize that cognitive impairment is extremely common as you get older. This is the simplest means to check cognition. And if you have to know one test, at least understand the mini-cog. It's often asked in the exam, if you have to have a large gathering of applicants to a program or to a school or college, and you want to check cognition, what would you do? This test would take less than 5 minutes, 3 to 4 minutes. You mention 3 words, 3 different words. Example, a pony, a dollar, and an apple. 3 different words. Repeat it one more time to make sure the patient heard you properly. And then say, I'm going to get back to you on these 3 words. Ask the patient to next draw a clock, a simple clock. You're allowed to draw the outline of a clock and give it to the patient if you wish. Ask the patient to place the numbers, place the time at 10 minutes past 11 or 20 minutes past 11, and see whether the needles were placed in the right areas and the clock was overall correct. So 3 items. Now you go back and ask the patient, what were those 3 words I just mentioned? If the patient got all the 3 words correct, that's the end of story. The patient is cognitively intact. If the patient got none correct, the patient likely has dementia. If the patient had 1 or 2 correct, you need a perfect clock. So that's how you kind of score the patient, and you can decide. This is a very sensitive test for cognitive impairment. And if this is giving you a score that suggests dementia, you have to realize that everything you're going to do for the patient from then on, irrespective of your specialty, has to be taken with the fact in mind that this person may not be able to exactly determine what is right or wrong for this patient. And that goes back to capacity. In mild dementia, you can have capacity, but as your dementia progresses, capacity will be lost. So now, after finishing that introduction, I'm going to get into the area of gastroenterology in older people. And my first case is regarding appetite. And let's see, this 85-year-old woman with hypertension, anemia, and diabetes comes to you with weight loss of 15 pounds over 6 months. Now, that kind of weight loss is significant. It's at least 10% of the weight that she previously had just 1 year ago. And this needs evaluation as to the cause. The patient is on iron, enalapril, metformin, thiazide, and vitamins. She does not enjoy her preferred foods anymore, but adheres to diet recommendations for diabetes. You consider all of the following approaches in addressing the weight loss except one, all of them except one. Inform the patient that it's age-related, review and revise the medication regimen, screen for depression, and consider avoiding dietary restrictions. So anorexia in older people, it's a complex topic. It's a topic by itself for an hour. And I want to make you understand that it's not something simple. There are a huge number of consequences if you have anorexia, leave alone weight loss, its quality of life, and eventually getting frail and dying. It is not supposed to result purely from aging. There are many other factors, whether they are money, socioeconomic, depression, physiological, pathological. Simply having disease processes can cause you to be anorectic, liver disease or kidney disease, or the medications that you give. There are hormones which stimulate appetite, and there are hormones which suppress appetite. Now, there are 5 basic tastes that we all encounter: sweet, salty, bitter, sour, and umami, which is monosodium glutamate. There are controversies as to what you might lose as you get old, but better stated, they have taste preferences. They might tell you, doctor, I need to eat sweets. That's the only thing I enjoy. Or they might tell you, I hate salt. And that might be good actually, because salt is not a requirement as you get old. Please remember this. Salt is something we developed as a result of civilization. In the old caveman's ages, there was no such thing as salt. So we enjoy salt because we like to taste salty foods to some extent. But there are taste preferences. But contrary to that, olfaction is the one that consistently declines with age. And you might wonder, does that matter? Olfaction or smell matters as much as taste, which is less consistently altered with age. So I'm going to give you an example. If I was to go to the store, which I often do, my wife tells me to do the grocery. It's interestingly on Thursdays in the evening. And when I go there, I'm supposed to pick up some fruit. So let's say I have to buy apples. I look at the apples in the store, look at all of them with my eyes, and I see which one appeals to my eyes. And then I take one of them, see how they feel. Are they feeling nice and firm? And do they smell good? When I bring them, I'm actually smelling them, even though I don't recognize the fact that I'm smelling them. When you do want to eat the apple and you put it in your mouth and you crunch, you use your teeth, and then you use your tongue movements to roll it over and then to swallow. And in that process, you're also hearing the crunch. So you can look at how many sensations and features are involved in getting the joy of enjoying the apple. And that just tells you, if I don't want to eat that apple, there are many factors in play. So you're going to wonder, what should we do to any patient who comes to you with anorexia? When people come to me saying they completely lost their appetite and it started 1 or 2 months ago, my God, there's a high likelihood that it's a drug or it's depression. The last time this happened to a patient, I usually love to say stories. I know I'm going to divert, but one of the hospital employees brought in her grandmother with back pain, but that was not her complaint. When I inquired, she had lost her appetite completely. I asked to what food? She said all foods in the last 2 months. And when I dug in a little later, I found that she had been moved into an adult home, into an assisted living facility just 2 to 3 months ago. Now, instead of asking her in front of her granddaughter, is that why you're upset? I asked her a simple question. Do you miss your grandchildren or any other family? Do you miss them? And she cried. Immediately she cried. And that was the answer. I actually was in a very difficult situation of getting between her and the family member who was a hospital employee. I prescribed an antidepressant, and about 2 months later, this employee stopped me in the corridor and said, Dr. D, just wait. And when I waited, I thought I had done something really wrong. I was wondering, I was nervous, and she came to me and said, you gave me my grandma back. And I said, what do you mean? She's great. She's doing so well. So that was depression and complete loss of appetite. So look for a cause, not that we can address all the causes. Look for your medications. Many times this is right there. You have prescribed something like iron, which can cause you to lose your appetite. Look into the mouth, make sure that the dentures, if they are there, are appropriate. If they're missing teeth, that might be the cause. And most important, don't go to the route of giving medications to improve your appetite, because most of them have adverse effects. So onset of anorexia and old age, unless it's from a disease process, such as kidney failure or liver disease, it could be addressed, and it should not just occur. Dry mouth is a common problem from, for example, diuretics. So the answer here is, you do not tell the patient it's age-related, but look for a cause and try to see what you can do. This is very important. As you get older, don't put in a lot of dietary restrictions. Don't eat this, don't eat that, don't eat this. I remember a famous geriatrician who said in a very prominent national meeting, I think it was Dr. Auslander, he's very prominent. He said, if I ever end up in a nursing home and I demand a McDonald's hamburger, please give it to me. Don't put dietary restrictions. I want to be happy. I still remember that statement he made. So remove dietary restrictions. Now, I just threw in this slide. These are the dietary guidelines. These guidelines, US guidelines, are revised every 5 years. They're due for revision right now. If you look at this 10 guidelines that I chose from the whole manual, which is about 200 plus pages, I'll just run through some of them. Nutrient-dense foods, the 10% rule for added sugars, less than 10% of calories from added sugars or saturated fats, 2,300 milligrams of sodium or less. We all eat too much salt, even less for hypertension. Whole grains, fruits rather than juices, oils which are largely monounsaturated. You don't have to go for olive oil. Actually, canola oil is as good or even better. Corn oil, peanut is to your taste. Proteins, as lean meat, you can have a few eggs, not a lot of eggs. Legumes, nuts, and seeds. This is my favorite. This is my snack all day whenever I'm hungry. And fiber. So this is what you need to follow. Now we shift to medications. We all prescribe a lot of medications. We love to do that. And this is something we need to pay attention to. There is no number to define polypharmacy, but suffice it to say it is excessive and redundant number in proportion to the illness that the patient suffers from. And you often see polypharmacy. You don't have to define a number. When you look at medications, follow some criteria. This is one criteria I would recommend called the Beers criteria. This is just a few pages updated every year by the American Geriatric Society. If you know the Beers criteria, you're going to be a super prescriber, and consider deep prescribing, which I will address. So these are some examples of drugs that we do use in excess. We use anticholinergics whenever people have abdominal discomfort. We use far too many antibiotics. There was an article in the Annals of Internal Medicine just 2 months ago on the fact that we have this habit of prescribing 10-day courses of antibiotics, even to minor respiratory infections. We often, and in that article, they chose 5 illnesses, and they said most of them you need only 5 to 6 days. We use far too many PPIs, which I'm going to address. Laxatives, as soon as the patient says constipation, we tend to use a laxative rather than determine a cause. We use excessive use of NSAIDs, sleeping pills, vitamins. And so these are just a few examples. If you use too many drugs, they interact with each other, with other nutrients, which causes a new problem or disease processes. And this is what causes adverse drug events. So for example, if you use phenytoin, and phenytoin might be appropriate, don't get me wrong, you need to be aware that through a liver metabolic process, they decrease vitamin D levels. So rather than just not be aware of this, those patients might need vitamin D. Warfarin, when you use green leafies, the dietitians or nutritionists often tell the patient, don't take green leafies. That should not be the answer. Levodopa, don't take food protein. You have to require food protein. So what would you tell the patient? Use green leafies, but use them in a controlled manner and a regular manner rather than binges of any item, including green leafies, a lot of them on one given single day and none for the rest of the week. So if you use some green leafies, you're providing some vitamin K, you will adjust the dose of warfarin. Levodopa, carbidopa is taken best on an empty stomach with water. So that you don't tell the patient not to take food protein. That would be a horrible advice. Grapefruit is different in that half of America takes grapefruit. So we need to be aware. I tell patients, I had one patient who came 1 month, actually before she died. I only knew she died later. 1 month with a terminal illness, and she asked, can I please take grapefruit juice? I said, how much would you like to have? She said, just a glass. I said, as long as it's a glass and you want to take a glass every day, that's fine. As long as you don't go with a large container. She was on a lot of medications which would be affected. She was so happy. 1 month later, she died. And I was so happy that, not because she died, that I did not say no to her. And oftentimes people say, don't take grapefruit juice. That's not some. Actually, they make these drugs more effective, statins and calcium channel blockers. So now question number 2, PPIs are commonly used inappropriately on a chronic basis for vague upper gastrointestinal complaints. A patient of yours is on PPIs for dyspepsia for over a year. That's what patients tell you, that I'm actually having dyspepsia or these discomforts upper abdomen. All of the following have been associated with the chronic use of PPIs, except which one? The consequence. Do they get a deficiency of B12 or folic acid? Do they have more fractures, or do they develop iron deficiency? This is chronic use of proton pump inhibitors. And the answer is all of them occur. This is only a fraction of what they may get, except folic acid. So you need to be aware that a lot of consequences follow the chronic use. The literature even talks about cognition, and I'm not going to say that that happens. This is the story of kidney disease and deterioration of kidney function, which you would not want to have from the unnecessary use of PPI. So what should you do? I will come to that in a few minutes, but question number 3, also referring to PPIs, the patient has gait abnormalities, 85 years old, from lumbar stenosis, is hypothyroid, already has CKD, and a history of falls. She takes combinations of ibuprofen. Now she's taking an NSAID, tramadol, and lidocaine patch for pain, and uses omeprazole, obviously for the ibuprofen side effects, of 40 milligrams daily for over a year. The hemoglobin is 10, so she's already anemic and she has iron deficiency. She does not want an endoscopy. So she comes to you and she does not want an endoscopy. Your approach to the use of PPIs in this patient includes all of the following, except which one? Do you want to continue PPIs because she's on ibuprofen? Do you want to advise tapering the PPI and stopping the NSAID? Do you want to suggest intermittent use of PPI as a trial? Do you want to educate regarding adverse drug events of PPIs and a tapering plan? Now, you must understand one of the formal indications, if you look at the guidelines, is that if you are on ibuprofen, you are justified by using a PPI, but how long should this continue? So this is where we have coined this term called deprescribing. This is in vogue now for about 6 to 8 years. It was more utilized in other countries such as Canada, but America is catching up. And we did a project where we showed that it is possible to deprescribe medications. And so if you are encountering a patient, you verify why this PPI is being used. Is it being prescribed by the doctor when you have control, or is it over the counter? Is it beneficial? Is it consistent with the guidelines? In her case, it is consistent with the fact that NSAIDs demand the use of PPIs, or is it unnecessary and can it be discontinued? If it can be discontinued, great. If it cannot, can the dose be reduced? You have 2 options. If either answer is no, then deprescribing is unsuccessful. But if it's possible to do either, discontinue or lower the dose, you follow up. You don't just do it, but you follow up for complaints post deprescribing. If none occur, you are successful. And if complaints occur, you reinstitute the drug. So this is an algorithm which we developed to re-prescribe any drug, and I've used PPIs as an example. The Canadian guidelines tell you that you should not maintain, this is the Choosing Wisely guideline, incidentally, don't maintain long-term PPI therapy for GI symptoms without an attempt to stop or reduce the PPI at least once per year in most patients. Exemption, GI bleeding, and Barrett's esophagitis. So these are two obvious. I would add Zollinger-Ellison syndrome. So there are some examples which are exceptions. So you should make an attempt. You don't succeed all the time. And so the answer here is not to tell her, continue the PPIs, but you really would try one of the others. You would try to stop the NSAID and thereby taper the PPI. Or if she's still hung up on the PPI, can you use it intermittently? Can you use it 3 days a week, which by the way, a lot of patients agree to. Can you do it for a month and stop it and see what happens? And then if you want, use it for a week or two. Then the patients are amenable. You have to show the patients that you care and that you're willing to try an alternate plan. And if you succeed, this is just one example where you can succeed in deprescribing, but there's a whole list of drugs you can deprescribe. And we found that 25% of the medications that patients use could be deprescribed over the course of 6 months in the study that we did. So deprescribing is here to stay. We all should attempt it. In every field, there are unnecessary drugs that we give to the patient. We next go on to a topic known as dysphagia. So there's a general comment I would like to make. Dysphagia generally needs evaluation, and iron deficiency also needs evaluation. We'll talk about iron deficiency at the end of the talk. Now, dysphagia, which I'm going to refer to, is transfer dysphagia, which occurs right up the gastrointestinal tract, where there's difficulty in transferring food from the mouth to the upper esophagus. If you have dysphagia lower down in the esophageal area or esophageal dysphagia, that definitely needs evaluation because you might be dealing with a tumor or a stricture. We are not talking about that today. When there is difficulty in transferring, it's not a simple answer because it's a complex problem, just like anorexia. It involves a lot of muscles. It involves the nervous system, central and peripheral, and it involves the muscles of the oropharynx and larynx. And the disorder is not that easy to reverse. For example, Parkinson's disease, stroke, you've already had the stroke, or dementia. Bad news. So what can you do? What is the consequence? The consequence is coughing, often while you eat. You simply ask the patient, are you coughing while you eat? Aspiration and pneumonia and poor quality of life. So people come to us with dysphagia, and as I'm going to illustrate in the next few slides, a common problem, oropharyngeal dysphagia. So this is a slide that refers to the consistencies of foods. This is from the International Dysphagia Diet Standardization Program. And you can look at drinks which are water thin. This is water, thinnest. And you can look at regular food that we all eat, which is the thickest. So there are grades from 0 to 7. And in patients with oropharyngeal dysphagia, you might be interested in choosing food that is somewhere around here. And that is what the nutritionists do. If I'm to describe what does that food feel like, it's like honey or nectar in terms of consistency. This is easier to swallow. You can change a liquid such as a juice, which is slightly thick, or a glass of coffee by adding what is known as a thickener and changing the consistency, because this is more likely to be swallowed with ease rather than very thin, and these very thick are equally difficult. My own mom in the nursing home recently, she has Alzheimer's, she's in her 90s. She has had it for over 5 to 6 years. She takes a lot of time. She was evaluated by the nutritionist with these different foods, and she came up with a plan that she's still good for soft and bite size. You don't have to change the meal. So these nutritionists try different consistencies, and then you have the head up position, not the lying position, chin down, and that's how you eat. So before I say that that's what you should approach, this is the key statement, a very important statement. Do not offer PEGs to patients with advanced dementia. Instead, offer oral assisted feeds, otherwise known as comfort feeds. All of our perceptions regarding PEGs, we do a lot of PEGs, including our hospital, and I'm always anti-PEG because PEGs do not change your life expectancy. do not improve your quality of life. By the way, do not decrease aspiration. It's actually more common, and they do not prevent your pressure ulcers. So the longevity following a PEG in advanced dementia, which is when you place a PEG, is often months or less than a year to year and a half. So most patients end up dying. I'm not saying everybody does. The exceptions, less than 10 to 15% of patients will go beyond 2 years. So a lot of our perceptions are wrong. The reality evidence proven is otherwise. So when you get a patient with PEG, who is indicated for PEG, I'm not saying I get the patient with PEG, but once in a while the nursing home literally sends the patient for placement of PEGs. So is that correct? First of all, determine the patient's capacity. Is the capacity present at this time? And you're likely going to find out no, because this is advanced dementia. And before you go to the caregiver's opinion, find out what this patient had wanted in the past. Is there an advance directive? What did this patient tell you in the past? Did she actually want everything to be done to keep her alive to the very end? After that, as the caregiver, what would you do? And before you say what you would do, is that what the patient wanted? It's what the patient wanted. If all this is a conflict and you find that you don't go anywhere, you might use a multidisciplinary approach. But before that, find out whether there are any reversible factors. There are often reversible factors, as I'm going to demonstrate. If there are reversible factors, that is great. If the patient's caregiver asks what else can be done, your answer would be to suggest comfort feeding. And if you are going to agree for the PEG, which you are forced to do sometimes because of the caregiver's strong beliefs, you are not going to, the word used, do not give undue favorable prognostic answers. That the patient is going to do great, will not aspirate. That's exactly the opposite. You should bring out the negatives. You agree to give the patient the benefit of the doubt and place the PEG, but don't promise wonders. Now, on the other hand, if you have a stroke, you could place a PEG on a temporary basis if you think that the life expectancy is beyond 4 weeks. That's allowed, and the PEG comes out. If there's advanced cancer where there's a swallowing problem in the gastrointestinal tract, rather than a PEG, you would be placing a gastrostomy, and that's not an ethical problem. So this has some ethical considerations, and you should resort to comfort feeds, which means sitting the patient up, feeding slowly and with time, and with what we call as therapeutic touch or tender loving care. Why is this not being done? And that's what is happening now to my mom. We have actually employed people to sit with her. We pay for this so that they can feed her for all her meals, and she's eating fine. And with this advanced dementia that she has, we have determined that we are not going to put in a PEG at the very end of her life. Now, this is sometimes colloquially referred to as pleasure feeds. The correct term is comfort feeding. So this is a case where there was difficulty in feeding, and this patient got an endoscopy to look for any obstruction. And lo and behold, this is what we found in the pathology. They actually put in a gastrostomy before the results came out, sadly, because she had lost 30 or 40 pounds. But this indicates they were all medications or crystals in the pathology specimen. This was pill esophagitis. The pills had blocked the lower esophagus, which was ulcerated. The endoscopic findings suggested that the ulcer might be cancerous, but it was not. And the good story is in about 3 months, all that healed. And she started eating. She had the gastrostomy, and she started putting on weight, and she said, I can eat normally. And the gastrostomy came out. This was actually one of our cases. A second story where a patient loses weight, comes into our facility, and the nursing home had asked for a PEG. This person had lost 30 or 40 pounds, had a language barrier. After a lot of trouble, we got this patient to speak in his own language. And with difficulty, we found out his memory and cognition was perfectly intact. He could name all the previous presidents, which I could not do. So what was wrong with him? Well, in further evaluation, this guy had Parkinson's disease. So the neurologist came in and evaluated him. He could not eat. He was weak. He had lost weight. We got him to take medications, essentially levodopa, carbidopa. The guy improved dramatically, went back to the nursing home without a PEG, and in 3 months gained most of the weight that he lost. He was eating like a pig. So look for a cause. Now, Having finished PEG, let's talk briefly about constipation, which is a burden in that it's very common, even causes hospitalizations, and we all treat with medications. So the first mistake we make is to just believe the patient's statement. We believe patients, but the patient says, I'm constipated and I want something, and you start the, you don't try anything else except to give a medication, because this patient has already tried over-the-counter medications and is coming to you after he or she failed. So does it really fulfill the criteria of bowel movement less than 3 per week and the so-called Rome criteria, which has been revised periodically? This is the last updated criteria, where 25% of the time you need to have 2 or more of these problems. In the interest of time, I'm not going to read all of them, and this whole thing should have lasted at least 3 months. I've seen people, even doctors, sometimes tell me they move their bowels only 3 times a week. I've also seen the other extreme of some people moving their bowels twice a day, which doesn't mean it's diarrhea. It's all your habit and what you do and what you can do comfortably. So before you decide that this is constipation, look for all this. They say before you refer the patient to a gastroenterologist, check the calcium and thyroid. This is high on the list. And the potassium. Low potassiums can alter your bowel motility. So these are very simple, but thyroid and calcium are high on the list. And also to see whether there are any neuropsychiatric conditions like dementia, where it's going to be great difficulty in educating the patient. Parkinson's disease is notorious. So you've got a lot of these problems, including depression, which you need to look at. And my favorite, there are tons of medications which can cause you to get constipated. Patients buy calcium over the counter and are taking 3 pills a day. Surely that could be a cause. Iron preparations that you have prescribed. And look at all these medications. So one of the basic fundamentals is be careful about anticholinergics in older people. If I'm going to choose one group of medications, it's anticholinergics, which not only cause constipation, but they actually make your cognitive function worse. If you have mild cognitive impairment or mild dementia, that's going to get worse. So this is what you need to do. And you should look for alarm signs. One time a doctor in my hospital came to me. He was in medicine, a very bright doctor. He said, I'm concerned. And he told me, I've developed constipation of 1 month's duration, 1 month. I said, you need to get checked. Sudden onset, with or without weight loss, and rectal bleeding. Iron deficiency equals anemia and GI blood loss in many people. So when this person told me this, he, just to make a long story short, he had a huge mass. He had cancer, essentially. So sudden onset, instead of trying to do all kinds of measures, check for alarm features, check the few blood tests that I told you, and then get this person evaluated, because that could be a serious problem. So when I meant constipation, I meant long-standing, over 6 months. And there you're going to work on bowel habits, use of the gastrocolic reflex, which we all have. I have my gastrocolic reflex. In my case, it's triggered by coffee. So I have to get up and have my cup of coffee, and then I get my gastrocolic reflex to work. It could be a warm drink. It could be milk. It could be anything. And timing is everything on a regular basis. It could be every morning, and you try to evacuate by giving 10 to 15 minutes in the beginning. Later, it gets shorter. One patient said, I'm asleep all day. I'm a night worker. So that was interesting. I said, you could do this in the evening. Discourage routine laxative use. And you might need to call anybody. It's not always the gastroenterologist. There could be a psychiatrist involved in this patient. So I just want to tell you, it could be a cancer specialist, depending on your condition. So there's a lot of talk on what you should drink, but just drinking water is not going to do the trick. I've put it in small print. Just drinking water means if a patient comes into the hospital giving intravenous fluids, you're going to evacuate your bowels. It's not going to work. So you need to know it's a combination of activities, but exercise. That means move. After walking, after you finish your meals, walk. That's generally a good advice. Timing is ideally about 30 minutes after meal. It's even good for diabetes. That drops your blood sugar, incidentally. So physical activity doesn't have to be running, but walk. Walk after your meals. Drink enough fluids. Not the wrong fluid, which is A lot of coffee. Coffee is fine. It may even be healthy, but not a lot. Consider certain foods or juices. Always fruits better than the juice. Prunes, even kiwi fruits are considered to be, they all have ingredients. It's not psychological, but they have ingredients which help the movement. In the case of prunes, it is phenolphthalein. So a combination will help. And rather than tell you add more medications, revise your medication regimen. We must have enough fiber intake. I mentioned this. America as a whole is inadequate. This is what we do. Normally less than 15 grams a day. It is considered to be one of the 5 nutrients of concern by the US dietary guidelines. We need a lot more of soluble and insoluble fiber. And at the minimum, we should be in that 20 to 30 grams. We don't need 50 or 60 grams per day of soluble and insoluble fiber. And you can do it in a bunch of ways. I did not utter the word medications. I would say fruits rather than juices, vegetables. A lot of items have fiber. If you must eat cereal, bran is rich in fiber. So these are some of the ways that you can encourage fiber. My favorite is have a bowl of milk with bran cereal, bran, sliced bananas or some fruits, put them in the cereal, and it is quite delicious. And I honestly have tried this a lot. Many nursing homes give combinations for breakfast, but the principle is to increase your fiber intake. Question number 4. A 90-year-old frail nursing home resident is too deconditioned to get out of bed. She has a history of chronic constipation and has been a long-standing laxative user, which is ineffective. Her abdomen is distended. The staff mentioned that she has small amounts of liquid stools. Now, whenever people mention that, we think of C. diff. So is that what you're going to look for? Are you going to do a rectal exam, or you're going to alter the fiber intake, or you're going to give an enema followed by osmotic laxatives? What are you going to do? This is liquid stools in a chronically constipated person with abdominal distension. So really, this patient has what is known as fecal impaction and factitious diarrhea. I recall seeing such a case when I started life as a resident in this country as a PGY1. I still haven't forgotten how my senior resident said, give an enema, and I didn't know why. It's hard stools, and the stools liquefy above and seep down. It is solid impacted stools, but the stools above putrefied and seeping down. And that is what is fecal impaction or factitious diarrhea. Now, just giving a laxative is not enough. First of all, you have to fragment the feces. You will need to do a rectal exam and clear that. And now develop a long-term bowel regimen. It's not going to be immediately giving a laxative. So this is such a chronic problem that the bowels have lost their muscle and nerve function, and this is not going to be easy to reverse. So you should start with a rectal exam and then see what you can do as a long-term strategy. This is an extreme case, factitious diarrhea. My last comment, and in the interest of time, I'll be brief. We all need to be aware of anemia. And here I'm going to say that 1/3 of all anemias, this is US statistics from people 65 and older, NHANES data. 1/3 of all anemias is nutritional, which means the gastrointestinal tract. I think I told you whenever you have iron deficiency, you should look for a cause, but you could determine this 1/3. 1/3 results from some forms of disease, and 1/3 will be hard to figure out. So anemia is not just a number, it has consequences. It results from a cause. It's a serious problem. Sometimes it may be cancer, sometimes it might be bleeding peptic ulcer, but it's from a cause and it worsens all other functions, causes you to be weak, causes you to get depressed. You cannot walk, your gait is impaired, your heart is disordered, there is LVH, you get depressed, and now it even predisposes to CKD. So this is a simple slide, tells you what all can occur if you become anemic. But these anemias are not so simple. This is B12 deficiency, and rather than tell you a simple explanation, I just want to tell you B12 absorption is very complex. There's a huge numbers of steps, and that's why B12 deficiency is so common. But all of them are in the GI tract. I want you to know that half of B12 deficiency is from failure to split B12 from food protein. Half. It's not pernicious anemia. So it's a very complex problem, and therefore it's very common. So with regards,
Okay. Well, I don't have anything, so ask them to fax it again.
With regards to treatment of cobalamin deficiency, all of the following are true, except vitamin B12 deficiency can be prevented by regular use of vitamins containing B12. B12 in large doses corrects most causes, including PA, pernicious anemia. Correction reverses hematological manifestations, but not neurological deficits. And B12 must be administered routinely for anticipated deficiency following bariatric surgery. This is just a question. So if you look at all these causes of B12 deficiency, I'll just say this is the most common: food cobalamin malabsorption, where we failed to promote the split of cobalamin from food-bound protein outside our body. When we take in, we need to split it, or we don't do it. PPIs also cause B12 deficiency. This is a study that I demonstrated. This was actually the first study that was done over 6 years. And you see the B12 levels come down on chronic PPI users. Unlike folate, so this is green, folate, which is widely dispersed in fruits. Beyond green leafies, B12 distribution in foods is sparse. You need to be aware of this. So it's harder to get B12 just from food alone. Whereas you can get folate, you can by good food habits. So the answer is you can't just prevent it by using multivitamins. You need to go further. You need large doses of vitamins. And if you do it in time, you can reverse the hematological manifestations, but not the neurological deficits. You also should get B12 routinely after bariatric surgery. My one comment before I go on to question is that iron deficiency always warrants evaluation. If your patient is iron deficient, look for a cause. It could be something serious. So with that, in the interest of time, I'm going to stop. We have started now the newest recommendation. I just threw this in because this just came out. Start looking for colorectal cancer screening earlier in life. We do it between 50 and 75. The age is now lowered to from 45 years. It's a grade B recommendation. So with that, I'm going to stop. I'm sorry I rushed the last few slides in view of time, but I'll now take any questions or comments as you might regulate.